The hormone is progesterone, not estrogen, not cortisol, not insulin, though all three matter and all three are real contributors to what happens to a woman's body after 50. Progesterone, the one that drops first, the one that starts declining years before menopause is officially diagnosed. The one that most conversations about menopausal weight gain skip entirely because estrogen gets all the attention. In the research summaries, in the clinical guidelines, in the conversations women have with their doctors when they describe gaining weight around their midsection, despite doing nothing differently than they did at 42. Why does progesterone get skipped? Partly because estrogen is the hormone most associated with femininity in the cultural imagination, so its decline gets treated as the defining event of this transition. Partly because the symptoms of low progesterone, weight gain, disrupted sleep, anxiety, bloating, mood changes, are so similar to a dozen other things that they rarely get attributed to the right source. And partly because the relationship between progesterone and abdominal fat is not a simple, linear story. It works through four separate biological pathways simultaneously, and explaining it properly takes more time than most appointments allow. That's what today is for. Here is something most women are never told about perimenopause. It doesn't begin with estrogen, it begins with progesterone. The ovarian decline that characterizes the transition toward menopause is not a simultaneous drop in all reproductive hormones. It's sequential. This distinction has enormous practical consequences for understanding belly fat, because progesterone is not simply a reproductive hormone. It is a systemic regulatory hormone. When progesterone declines, all four of those systems shift simultaneously, and they shift in the same direction, toward more fat storage, specifically in the visceral compartment. Let's take the cortisol relationship first, because it is the most direct and the least known. Progesterone and cortisol compete for the same receptor. Both hormones are structurally related. They are both derived from pregnenolone, the master precursor steroid hormone, and they bind to overlapping receptor families. Progesterone, at physiological levels, occupies glucocorticoid receptors in adipose tissue and partially blocks cortisol from binding to them. It acts, in the language of receptor pharmacology, as a partial glucocorticoid antagonist. In plain terms, progesterone blunts cortisol's effect on fat cells. Cortisol signals visceral adipocytes, the fat cells in the abdominal region, to take up circulating fatty acids and store them. This is one of the mechanisms by which chronic stress reliably produces belly fat. Cortisol's fat-storing signal is real, and it is strongest in the visceral compartment, because those fat cells express glucocorticoid receptors at higher density than subcutaneous fat cells elsewhere in the body. When progesterone is present at adequate levels, it competes with cortisol for those receptors. The fat-storing directive is attenuated. When progesterone is low, as it is from the early perimenopausal transition onward, cortisol acts on visceral fat cells without meaningful opposition. This is why women frequently describe the belly fat of this transition as appearing despite no change in diet, no change in exercise, no change in anything they can identify. The second pathway runs through the thyroid. Progesterone supports thyroid function through multiple mechanisms. It enhances the sensitivity of thyroid hormone receptors in target tissues, meaning the same amount of circulating T3 and T4 produces a stronger metabolic signal. It reduces the conversion of T4 to reverse T3, an inactive form of thyroid hormone that competes with the active form for receptor binding. Many women who report fatigue and weight gain have normal TSH values and are told their thyroid is fine. But if progesterone decline has shifted the ratio, the consequences are present. Lower effective thyroid signaling means lower resting metabolic rate. The body burns fewer calories per hour in every state, at rest, during activity, during sleep. The third pathway is sleep. Progesterone has direct neurological activity that is entirely separate from its reproductive functions. In the brain, progesterone is converted by an enzyme called 5-alpha reductase into allopregnanolone, a neuroactive steroid. Allopregnanolone is one of the most potent positive modulators of GABA receptors known. GABA is the brain's brake pedal. Adequate allopregnanolone production facilitates the transitions into and out of deep non-REM sleep and reduces nighttime cortisol. When progesterone is low, GABA activity is reduced. The result is light, fragmented, unrestorative sleep, the waking at 2 in the morning. The fourth pathway is insulin sensitivity. Progesterone's relationship with insulin signaling is more nuanced than the first three pathways. In the context of normal physiological cycling, high progesterone in the luteal phase produces mild insulin resistance, which is rapidly resolved. What changes after 50 is the context. The loss of progesterone's cortisol buffering effect, combined with the sleep disruption I described, creates a chronically elevated cortisol environment. The insulin resistance of postmenopausal women is not caused solely by progesterone decline, but it is a meaningful contributor rarely included in the explanation. So the complete picture looks like this. Progesterone declines, cortisol acts without buffer, thyroid signaling decreases, sleep degrades, insulin resistance increases. That is why it does not respond the way it used to. That is why the walk you added, the calories you reduced, the protocol you followed that worked at 40 produces nothing at 53. Not because your effort is insufficient, because the hormonal terrain in which those efforts are operating has changed in ways that require a different response. What can actually be done about it? I want to answer this with precision because the popular wellness space has produced a substantial volume of content. The most directly relevant and most consistently supported dietary and lifestyle factors are these. Chronic stress management is not optional for this conversation. It is central to it. The cortisol-progesterone competition I described runs through the same biochemical pathway as the stress response. Chronically elevated cortisol promotes the enzymatic conversion of progesterone into cortisol precursors, a process called the pregnenolone steal. This is not a soft recommendation. It is the most direct nutritional and behavioral lever available for supporting progesterone availability in a body that is no longer producing it from the ovaries in sufficient quantity. Zinc is a cofactor for the production of progesterone in the luteal cells of the ovary and in the adrenal glands. Zinc deficiency impairs progesterone synthesis at the enzymatic level. The foods richest in bioavailable zinc, oysters, beef, pumpkin seeds, lentils, chickpeas, support the progesterone production that remains available in this transition. A 2020 study found that postmenopausal women with lower serum zinc had significantly lower progesterone metabolite levels than those with adequate zinc status. Vitamin B6 supports progesterone synthesis through its role as a cofactor for the enzymes involved in steroid hormone production. It also supports the conversion of tryptophan to serotonin, which independently supports sleep architecture and reduces the anxiety that elevates cortisol. Foods high in B6, salmon, poultry, potatoes, bananas, sunflower seeds, contribute to multiple aspects of the hormonal environment relevant to this conversation simultaneously. Magnesium supports progesterone through its role in modulating the HPA axis, reducing cortisol hyperresponsivity. This reduces the pregnenolone steal that diverts progesterone toward cortisol precursor production. Magnesium also directly supports GABA receptor function, complementing the GABAergic activity of allopregnanolone that I described in the context of sleep. Deficiency is extremely common in women over 50, driven by reduced dietary intake, medication effects, and age-related reduction in intestinal absorption. Dark leafy greens, pumpkin seeds, almonds, black beans, and dark chocolate are meaningful dietary sources. Cruciferous vegetables, broccoli, cauliflower, Brussels sprouts, cabbage, kale, contain indole-3-carbinol and its gut-metabolized derivative diindolylmethane. These support the detoxification of excess estrogen through specific liver enzyme pathways. In the context of perimenopause, where the estrogen to progesterone ratio is often skewed toward estrogen excess relative to the depleted progesterone, a state sometimes called estrogen dominance. Supporting estrogen clearance shifts the hormonal ratio toward more favorable progesterone relative activity. This is not supplementation. It is making available progesterone more effective. Reducing exposure to xenoestrogens, synthetic compounds found in plastics, commercial personal care products, pesticide residues, and certain food packaging materials that bind to estrogen receptors and mimic estrogen's activity reduces the degree of estrogen receptor saturation that contributes to the progesterone to estrogen imbalance. This means choosing glass or stainless steel over plastic, choosing personal care products with transparent ingredient lists, and avoiding microwaving food in plastic. These are not complete solutions. They are meaningful contributors to a hormonal environment that is modestly more favorable to whatever progesterone availability remains. And they do not substitute for a physician conversation if you are experiencing significant symptoms, including sleep disruption, mood changes, and weight gain. The conversation about progesterone and hormone therapy is one I want to address carefully. The evidence landscape is more nuanced than critics or advocates acknowledge. Progesterone therapy, specifically bioidentical progesterone, as distinct from earlier synthetic progestins, has been examined for its effects on sleep and body composition. Whether progesterone therapy is appropriate is a clinical determination that belongs in a conversation with a physician who has reviewed your full clinical picture. The biological mechanisms I have described are real, and they are modifiable to a degree through lifestyle interventions. The clinical conversation is worth having. To close, the belly fat that appears after 50 in women who are doing nothing wrong is often not a calorie problem. It is a hormonal problem. Specifically, it is a progesterone problem that has been expressing itself through 4 simultaneous biological pathways for years before it showed up visibly. Understanding which hormone is driving it is the beginning of responding to it effectively. Because the response to a cortisol buffering deficit looks different from the response to a caloric surplus. The woman who gains belly fat after 50, despite doing everything right, is not failing. She is experiencing the consequence of a hormonal shift that nobody has fully explained to her. That explanation is not a small thing. It is the difference between blaming yourself for a problem you are not causing and understanding a biological process you can actually address. If this gave you the explanation you have been looking for, hit the like button right now. Subscribe and turn on the notification bell. Every week there is one video here that does exactly this. Leave me a comment with this. Had you ever heard of progesterone's role in belly fat before today? Or was this the first time someone explained the cortisol connection? I read everything and I respond when I can.